Okay, we're going to continue on with thoracic trauma. So, when you look at statistics wise, chest trauma is about a quarter of traumatic deaths out there. Um, Early death tends to occur it's defined as within about 3 hours of the injury. And most commonly, it's associated with either tamponade or an airway issue, whether it's obstruction or aspiration. Um, and hospital mortality is not, if it's isolated thoracic, the mortality isn't horrible, but obviously multi-trauma, it can go up to about 35%. Etiology wise, their thoracic component in the civilian world is about a third of the injuries, most commonly blunt thoracic trauma from a blunt mechanism, whereas in the military world, it's about 15% of the injuries because of the presence of body armor, but it is more commonly penetrating. So the other thing to know is that from an intervention standpoint, surgically, not commonly seen with blunt mechanisms, but a little more common. About a quarter of the patients will need surgical intervention with penetrating thoracic trauma. And so what we're telling you is that from a management standpoint, most thoracic trauma in general can be managed with a chest tube or less, meaning observation. Early survival depends on those things that we catch during that, obviously the initial resuscitation, and then those things that we catch during the primary survey that need immediate interventions, like, tension pneumothoraces, things like that. Late survival, as in most trauma patients, depends on any complications that may occur. All right, initial evaluation. So primary survey, the standard ATLS is ABCs, airway control. We want to potentially use the FAST exam in the primary survey to diagnose certain entities. We'll talk about those, the resuscitation of the patient, and then any emergent procedures that may need to be accomplished before we move beyond the primary survey. We get into the secondary survey, we do a full physical exam, and we get some adjuncts like chest x-rays and labs to help narrow down the specific injury. This is a slide that talks about sentinel injuries that you can find, injuries to the chest and other injuries that may be associated with them. I'll review already. Let's see, 33-year-old female seen in the ED for an isolated stab wound to the right chest. She's hemodynamically stable and her FAST exam is negative. Vast majority of penetrating injuries to the chest are treated by what? Vast majority are treated by what? This kind of heck she has. Yeah, two answers. if you picked C or D, I think I put D, but C is also correct. So really, it's like chest tube or less, which is C and D. So both of those are correct. All right, let's move on. So we're going to talk about 5 life-threatening injuries here. So let's jump into these. The first is a tension pneumothorax. Clinically, it's a diagnosis that is made clinically. You actually should not see this chest x-ray. The physiology is that you have an entry of air into the space between the pleura, the parietal visceral pleura. They have been separated from each other, and you have air entering into that space, and it cannot get out. And so it continues to enter, and there's eventually a mediastinal shift to the contralateral side of the injury, and you start developing essentially the features of obstructive shock, which is compression of the mediastinum, decreased venous return to the heart, hypotension, etc. Signs and symptoms, there's a whole host of signs and symptoms associated with a tension pneumothorax. But what you really need to know is that there are only 2 signs or symptoms that you need to look out for. And those 2 signs or symptoms are unilateral breath sounds and hypotension. Essentially, a patient coming in with unilateral breath sounds, true unilateral breath sounds, no breath sounds on one side, and hypotension, that is a tension pneumothorax until proven otherwise, and should be treated so. Not with a chest x-ray. Most common cause, though, of tension pneumothorax is PEEP, actually mechanical ventilation with PEEP. So something to think about in a patient who might have, say, an apical pneumothorax, and you're sending off to the OR for 2 or 3 hours with the orthopedic folks to remember that if the patient drops their pressure in the operating room and you can't get it back, they may have developed a tension pneumothorax. Again, it's a clinical diagnosis. There are a couple ways to decompress this. The classic teaching is a needle in the second intercostal space, the midclavicular line. That can work fine. That's also the other choice is to place a needle or a chest tube in the normal location, the fifth intercostal space, somewhere between the anterior mid-axillary line. One thing that's interesting, though, is a paper out there showed that in placing a needle in the second intercostal space, mid-clavicular line, it took up to an 8 centimeter needle, 8 centimeter needle to get there greater than 90% of the time. That's something to consider and think about when patients come in from the field with field decompressions. Massive hemothorax, obviously, it's defined specifically as in an adult is greater than 1,500 cc's of blood, or a third of the blood volume in the chest cavity in a kid. Signs and symptoms, again, a whole host of these. Most commonly, you will, in a patient who truly has a massive hemothorax, you're probably going to see some sort of element of hypotension and then very dull breath sounds on one side. But the diagnosis really is not made until you actually enact a therapy. You can get a chest x-ray, which will show something similar to this, but until you actually put a chest tube in them and measure the volume coming out, then we won't really exactly have the diagnosis of massive hemothorax. In terms of when to do a thoracotomy or thoracoscopy, the classic textbook teaching is that on the initial placement of the chest tube, if you get more than 1.5 liters out, you should go to the OR. If you a couple other indications are if you get more than 200 cc's an hour out for, say, a 2 to 4 hour span, or if in your clinical determination the patient has ongoing hemorrhage, then just take him to the OR and fix the problem. Next is specifically talking about thoracotomies themselves. The indications for a thoracotomy are numerous. Obviously, persistent chest tube drainage, patients who have continued hypotension, although resuscitated them, they have chest trauma, can't get the lung to re-expand, et cetera, et cetera. There are certain reasons, not just ED thoracotomies, to go off and do a thoracotomy. Tamponade itself is the third thing we want to talk about here. Tamponade, compared to tension pneumothorax, actually comes more commonly from penetrating trauma than blunt trauma. And you need a high index of suspicion. Basically, this is where the FAST exam can come into play, especially in the primary survey, where you see fluid in the pericardium. You get the same physiology from a standpoint of shock. This physiology causes compression